Good afternoon, everyone, and welcome to today's webinar brought to you by Region 8 chapters of HFMA. The topic for today's session is Operationalizing Hierarchical Condition Categories, how to implement and be successful in your organization. We are scheduled to run for 60 minutes today, but before we get started, I would like to review a few housekeeping notes. All phone lines are on mute to avoid interruptions during the broadcast. In your audio panel, you may select to listen to this broadcast using your computer's mic and speakers, or you may select telephone to receive a dial-in number. To access a copy of the presenter's slides, please expand the handouts panel located to the right of your screen and select the PDF file. At the conclusion of today's presentation, we will have a Q&A session. However, you may submit your questions at any time by typing them into the questions panel located to the right of your screen. For today's webinar, I would like to welcome our guest presenter, Joy Krush. Joy has 30 years of experience in healthcare revenue cycle. She's worked at healthcare facility and health information with emphasis on coding, denial management, compliance, documentation improvement, and charge master. She has worked with Eide Bailly for the last 2 years performing coding review, revenue cycle assessment, charge master, and HCC reviews. Joy is involved in HFMA, North Dakota HFMA, currently holding the office of State Advocacy Coordinator. So without further delay, I'll hand the call over to our guest speaker. Joy, please go ahead.
Thank you, Nikki. And thank you, everyone, for joining us this afternoon to talk about HCC scoring. The big word of it is hierarchical condition categories, and that will be the last time I'm going to say that word. But if you wanted to go and Google that, that would be what you would be looking for. But what we're going to talk about today is HCC scoring. We're going to define HCC categories. We're going to talk about why they're important to your organization. How do they impact your organization? We want to understand common errors that can affect your HCC scores. And just talk about how you can operationalize processes to support accurate HCC scoring in your organization. Just hopefully today we can provide you some tips and tricks we've learned as we've done some HCC reviews and kind of how we can implement this process. If you've been in healthcare finance for a while, this kind of has the look and feel to me a lot like DRGs, but it's more the chronic conditions. This is across the spectrum, but just kind of have that in the back of your mind. The CMS HCC model was first introduced to pay Medicare Advantage plans. When the Medicare Advantage plans were first in talks and development, it became very obvious that when the Medicare Advantage plans would receive their per member per month payment for every member they cover, that'd be to their advantage if they took in only healthy Medicare patients. That was not the intent or the aim of the Medicare Advantage plan, so CMS early on recognized they needed to develop a risk adjustment system to pay these Medicare Advantage plans based on the complexity of the patient. So Medicare Advantage plans do not receive a standard per member per month payment. Instead, they receive a payment based on the specific patient and their needs. So that incentivized the Medicare Advantage plans to take on those sicker patients. How do we build an HCC score? There's a couple things that really are beyond our control. One of those being the gender of the patient. Male, female will impact the score. The reason for enrollment, did they age into Medicare, or did they come into Medicare through disability? The age of the patient, and then are they dual eligible? Do they have Medicare and Medicaid as secondary? And Are they a community? Are they in the community, or are they institutionalized? Are they in the nursing home? And then finally, the diagnosis codes will impact the HCC scoring. And this is where facilities and providers definitely have an impact on. Again, as we build the HCC score, there are 79 categories. And these categories are comprised of over 8,500 IC-10 diagnosis codes. There's 79 distinct ones that we can assign to a patient, and then each of which has a score correlated to the relative risk. There's about 10% of the IC-10 diagnosis codes that gave the HCC score. So much like, again, when we think about the DRG system, we've got certain diagnoses that are CCs, certain diagnoses that are MCCs. Now we have certain diagnoses that are HCCs. So certainly not all codes are mapped to a category. It's only those codes that are usable in predicting costs are going to be included in this. And then the categories themselves are going to be clinically related, and they'll have similar costs and resource use expectations. So an example of a category that's easy to kind of think about is diabetes. So category 19, diabetes without complications. Category 18, diabetes with chronic complications. So the patient that has diabetic nephropathy, diabetic neuropathy, and then diabetes with acute complications. That's going to be our diabetes with diabetic ketoacidosis, kind of that acute condition. The other thing then, next after the categories, are 31 hierarchies. And HCC codes in the same HCC category are mutually exclusive. So when more than one code from a category applies, we only use the code for the most severe manifestation from that category. So if we kind of go back to that example, we had diabetes without complications, and then we have diabetes with complications. They're going to be mutually exclusive, and only one category will apply. Over the course of a year, various providers will submit claims on a patient with multiple ICD-10 codes that are going to fall within these same HCC categories, such as the diabetes body system. That patient may have been coded, for example, on one claim with diabetes without complication, on another diabetes with complications. So it's only going to pick the HCC category that has the higher severity, and they'll only be assigned to that category at the end of the year. So again, 31 hierarchies of the 79 categories. Here's an example that just kind of gives you that visual of the diabetes again. So in this scenario, if a diagnosis from each of these categories were coded, category 19 and category 18 are going to fall off, and you'll only be scored with category 17. The categories, the hierarchies, and then finally we have something called disease interaction. And disease interactions are used to represent the additional resources utilized for certain conditions when a patient endures them in combination with each other. A good example of a disease interaction is congestive heart failure, because that has a disease interaction with diabetes. It has a disease interaction with COPD, with arrhythmias. So when those are in combination, we are going to get an additional disease interaction, because the thought process is that when you have those conditions in combination, you're going to have higher resources for that patient. And then also patients in an institution in a nursing home, there's some scenarios of disease interaction, as well as patients that are disabled. So here again is kind of a visual of this disease interaction. So if we have a patient that had hypertensive heart disease with heart failure, so that's a diagnosis submitted, And then they also had chronic kidney disease stage 4 as a diagnosis submitted. You're going to get a score of the 0.323 and the 0.237. But in addition, you're going to get another 0.27 added to your score for the disease interaction. The next example is a patient that's disabled and then has a pressure ulcer of the left elbow. Again, you're going to get credit in your demographics for the disabled. You're going to get an HCC score for that pressure ulcer, and then you're going to get the disease interaction. So what are the acceptable provider settings? You know, the short-term acute care hospitals, long-term critical access, rehab, psychiatric, in the outpatient setting, our rural health clinics, our FQHCs, provider-based clinics, standalone clinics are all included. What's not included, the non-covered settings, are, for example, swing bed. So your swing bed claims will not count in your HCC score. So diagnoses that are submitted on those swing bed claims or our skilled nursing facility claims will not be used for the HCC scoring. And so the other thing to think about are providers that see patients in the nursing home that has a place of service for the nursing home. Those are not used in the HCC scoring. Other services then are the non-covered services. One to kind of keep in mind is lab and radiology. So for a facility sending in their claims, you know, if it's just a straight lab or x-ray, the diagnoses on those claims will not be used in their HCC scoring. Who are the approved providers? A huge list here, multiple providers. The one that I will point out here that's not on this list are orthopedic surgeons or orthopedic specialty. And that, you know, it's something to definitely be aware of if you have a big orthopedic practice. Their claims, the diagnoses on their claims are not going to impact the HCC score, but certainly their documentation that goes back to their primary providers, you know, the primary providers can use that documentation for the diagnoses and, you know, eventually get those diagnoses captured. So on January 1st, the one thing about HCCs that's definitely important for everybody to remember that is on January 1st, it's a clean slate. So it's if the patient on January 1st is healthy again. And so if the patient has an amputation status, for example, you know, just a partial foot amputation status, that needs to get reported again the following year, each year, in order for that diagnosis to impact the score of the HCC. There's different things out there, but it's been stated that about 75% of all chronic illnesses are not coded and reported after the first year of diagnosis. It's kind of like we get into that maintenance mode of those diagnoses, and as long as things don't go acute with them, they tend to fall off with documentation. And while they may be stable if you talk to providers, whenever they're treating a patient for, like, let's just say an acute bronchitis and that patient has CHF, they're thinking about that CHF. They're thinking about the meds that patient is on to make sure that they don't, you know, do anything to cause that CHF to go into exacerbation. So it's just, that's what we have to get back to providers, that, you know, we need to get that stuff documented, that it is stable, but there are chronic conditions that definitely impact that patient. We're going to just go through an example of an HCC scoring to kind of give you an idea just exactly how this works. So this is an episode of care for a 72-year-old male who resides in a nursing home, and he's presented to the clinic with a complaint of shortness of breath. Now this is a completely fictitious example that we just made up. According to the documentation provided, the patient complains of dyspnea, fatigue, and persistent coughing. Recently completed antibiotics for a urinary tract infection. The urinalysis done today is clear. Patient appears frail with mild malnutrition. Previously diagnosed COPD, stable on Flovent daily. Patient continues to smoke. After radiological exam, the patient is diagnosed with aspiration pneumonia and sepsis. Antibiotic prescribed twice daily for the next 7 days. Ensure twice daily on a continual basis. So if you look at the example on the far left, what we're going to call our poor coding example, the HCC score of 1.323 is assigned based on the patient's age, gender, and residence in the nursing home. Then they assign the diagnosis of J18-9, just straight pneumonia. Straight pneumonia, pneumonia unspecified, does not have an HCC score. It's a score of 0. So since no other diagnoses were coded, the patient's total HCC score for this encounter, based on this coding example, would be 1.323. And if we think of CMS paying about $1,000 per 0.1, it's not quite $1,000, but the total cost for this patient, expected cost, is about $12,152. So in the next example, the better coding example, again we have the 1.323 for the demographics of this patient. Code J690, aspiration pneumonia, which is definitely documented in this note, is now assigned. The tobacco use is assigned F17210. Now that does not have any HCC score tied to it. And the theory we understand behind that is that it's not the tobacco use that's going to increase costs. It's the disease processes of the tobacco use. So now, due to the higher specificity coding of the pneumonia diagnosis, we've got a total HCC score of 1.39. Now we say our cost is about $12,700. So now let's look at the complete coding example. And when we look at this note, even though this note is not pages and pages long, we've got treatment. We've got the COPD is stable on the Flovent. The exam is showing aspiration pneumonia. We've got antibiotic prescribed twice daily for the next 7 days. The Ensure twice daily on a continual basis for the malnutrition. So in the complete coding example, now we have again, the demographics for this patient. Then we have the aspiration pneumonia for 0.067. Now we've captured the COPD, which is, what we typically see as the disease process coming from the tobacco use of a 0.305. The tobacco use, now we've added the sepsis that was documented and treated with antibiotics, 0.346, the mild malnutrition. And now here you'll see the disease interaction. So we have a disease interaction with the COPD and the aspiration pneumonia. So that's an additional 0.254 to our score, as well as another disease interaction with the sepsis and the aspiration pneumonia. So a disease score of a 0.321. So our total HCC score for this patient is 2.876. So what we are saying in this example is that we have an associated cost of about $26,416. So the HCC scoring correlates to the performance scoring of the cost category through comparison of the expected cost as communicated through the total HCC score to the actual cost associated with the episode of care. So if the actual cost of the episode of care equaled $15,000, let's say that's what it took us to care for this patient, The poor and the better coding examples would insinuate that we have ineffective care and resource utilization, because it's costing us more than we're reflecting it should cost us. For the complete coding example, the expected costs are above the actual cost of $15,000, and therefore we're communicating an effective use of resources and cost in this episode of care. Because what we're telling CMS, you know, when they're calculating our HCC scores, what can they budget? What can they plan to pay out? Are they going to pay out $12,000 to care for this patient? But if really, in fact, they are going to spend $26,000. So if you say $12,000 and it costs $26,000, we look inefficient. And if a patient's attributed to you, you're expected to coordinate that care, and you're responsible and you're accountable for all those costs. So that just kind of gives you an idea of how the HCC is tying to the cost. We'll go into a little bit about programs that utilize HCC scoring. Quite a number of programs actually use HCC scoring. Since it came out in 2004, CMS seems to really like this methodology, and most programs that have come out since 2004 are using HCC scores in some way or another. If you're involved in a Medicare Shared Savings Program, you're provided benchmarks for quality and cost. That is how CMS determines if you have a shared savings or a shared loss. A big portion of that calculation is affected by the HCC score. So every benchmark you are provided at the end of the year is risk adjusted based on the complexity of care your patient needs. So if we're not communicating to CMS the complexity of our patient population, they're not able to risk adjust our benchmarks appropriately for that patient population. So if you have a quality score and you have to achieve, let's say, 60% quality, then CMS will look at your patient population. Medicare has said that an average Medicare patient is about a 1.0. So if a patient comes in at a 0.8, CMS will state the patient is healthier than the average patient. And so they're going to expect a higher quality score, a better health outcome for that patient that's healthier than the average patient. But if you communicated that that patient was a 2.0, now you've shown that you have a more complex patient and they have needs that are above the average patient. CMS will adjust the benchmarks down as they will understand you're going to have a more difficult time achieving that higher benchmark based on your complex patients that you care for. You know, we've just not been always good at communicating with CMS the complex care our patient needs. You know, if you're paid under PPS, we've known this. The same theory has been in the MSDRG system, that we've had to reflect the severity of the patient in order to get paid appropriately. In critical access hospitals, we haven't been reimbursed under DRG, so we've gone away a little bit from that focus. The other thing is in the physician office setting, we've been fee scheduled, and so our day-to-day reimbursement hasn't been affected by this. And so you could, you know, see that patient do your level 4, and if it was pneumonia, that probably is going to meet the needs of that claim. But again, we're not then communicating just exactly what the complexity of our patient is. And this is where we need to be more transparent about our, you know, how our patients are. I think about the patients in the rural settings. You know, they care for some very complex patients because some of those patients won't go and seek out specialists. They're going to go to their primary care provider in that rural health setting for all the conditions. And so it's important in that rural health setting when we see that patient that we let CMS know all their conditions, not just the one that's acute today, all that are affecting the care that we're providing that patient. So again, we talked earlier about the Medicare Advantage plan, and that the higher the HCC score, the higher the Medicare Advantage payment per member per month. As you think about this in your organization, we know we're seeing more and more Medicare Advantage patients. That's becoming more prevalent all the time. So if you know your HCC score is high and that you have some complex patients, and you know that your Medicare Advantage plans are receiving a higher payment, it's important to understand your HCC scores, and this would give you opportunity to sit down with those Medicare Advantage plans when you're doing contract negotiations to talk about the impact of the HCC score on your payment as well. CMS started a new program, CPC Plus, and that's Comprehensive Primary Care Plus. This program rolled out to select regions in the U.S., and we had to apply to be a part of it. What we have seen here is CMS is actually providing upfront payment to organizations that are in this program based on a patient's HCC score. What that tells us is that CMS is integrating this information and this methodology more and more into their programs. So again, just another reason we want to focus on this methodology in our organization. I just don't think we're going to see this risk adjustment, this HCC scoring, going away anytime soon because it's just getting so tied into all of these programs. The other thing to keep in mind is CMS is very much using HCC scoring in MACRA. If we think of our previous models that rolled into MACRA, the value-based modifiers, if you reviewed your QR-UR report, CMS was using your HCC scores to track expected costs for patients and to see how efficient you were in caring for those patients. So they've rolled this into MACRA, and this is how you're going to be scored in the cost category. There was discussion in 2018 that we would not be possibly scored on the cost category, but the final rule does indicate that the cost category will be scored at 10%. And the other thing to be aware of in the 2018 performance year is there will be bonus points for complex patients. It sounds like there could be possibly up to 5 points, and two components that those bonuses will be paid on will be the average HCC risk score as an indicator of the medical complexity, and then the dual eligible ratio as kind of an indicator of the social risk. So again, this is CMS wants us to focus here. They're incentivizing us to focus here, and they will be scoring us. We'll talk a little bit about new modifiers and codes that are coming out. There's been some new things in the final rule on this. We have care episode groups, patient condition groups, and patient relationship categories, and we'll go into a little bit of detail of each. The patient relationship categories, we were under the understanding that those would be effective January 18, 2018, but they did come out and state that they've finalized the level 2 HCPCS modifiers to be used on the claims to indicate these patient relationship categories. But they further refinalized a policy that the reporting of these HCPCS modifiers may be voluntarily by clinicians associated with these patient relationship categories. We anticipate there will be a learning curve, which coming from the claims coding standpoint, I can tell you there's definitely going to be a learning curve here. And so this is the time to work with clinicians, work with the coders to ensure the proper use. We know these are coming. I mean, they're in MACRA, and what the final rule didn't really indicate is when. Is it going to be the next year, or could it be mid-year? So I think it's something that we don't want to put under the rug. We don't want to put on the back burner. We want to start using. So what are they? Patient relationship categories, again, they'll be accomplished via new modifiers. We now have those modifiers. It'll be on every claim that has a professional service on it, so your 1500s, your UB, when you're billing method 2. There are 5 modifiers, and what these modifiers do, if a patient is attributed to you as an organization, what CMS has stated, you're assuming responsible for the cost of that patient. If you're seeing the patient in primary care and you refer to another organization for specialty, from CMS's perspective, even though that other organization is going to be reimbursed for that visit from CMS, your organization is accountable for the cost of that visit. So what CMS is trying to do with these patient relationship modifiers is to be more transparent of who's responsible, who's accountable for the cost. So I'm just going to go through an example because that seems to maybe make it easier to understand. Let's say we have a patient that goes in to see the primary care provider. They're being seen for their diabetes, and their diabetes isn't under very good control. And so the primary provider has made the decision that it needs to be managed better and feels that he or she needs the expertise of an endocrinologist. So for this primary care visit, the coder will code this claim. They'll append a modifier in this visit that's going to state the relationship of this patient to the provider. This provider is their primary care provider. So that tells CMS that this primary care provider is accountable for the cost of that visit when they do their scoring for the cost category. And we know, again, this will be used for MACRA, and we anticipate other programs will use this as well. So now the primary care provider writes an order for referral to the endocrinologist. When the patient goes and sees that endocrinologist, this physician will then, manage or see the patient, take care of the patient's diabetes. But let's just say endocrinologist decides, you know what, yeah, your diabetes is very out of control. I'm going to need to see you for the next 6 weeks to make sure we've got this under control and monitor this. So for that first visit where we had the referral, the endocrinologist claim, there'll be a modifier appended to that indicates that you saw this patient, but on a referral from the primary care provider. By appending that modifier, the cost of the first visit will go back to the primary provider. So then if the endocrinologist then sees the patient in follow-up and in essence, taking over managing that diabetes for the next 6 weeks, the modifier that needs to be appended to those subsequent visits will indicate that now the specialist is taking over care for this diagnosis. So now the cost of the subsequent visits will be attributed to the specialist, and they will be accountable for that care. So I think the thing to keep in mind with this is that organizations who do this well will appropriately communicate to CMS who is responsible for the cost of the visits and the cost of caring for a patient. Organizations that do not do this well may inadvertently take on more costs than they should, and they'll be scored according to that under MACRA. So it's important to understand this as you look to implement this in your organization. The providers, the clinicians need to understand these modifiers because they need to document their visit. Was it a primary care? Was it a referral? Am I taking over that care? And then the coders need to understand these modifiers so they can appropriately assign the modifiers. This is going to have a large impact on your scoring in your CMS programs. The other thing to keep in mind too is, and this is our time to do this, are your billing systems today ready for those modifiers? Will they accept those modifiers? And then let's be sure that when our claims go to the clearinghouse, that we don't have them being scrubbed out on the back end. So the other thing is cost episode groupings under the cost. And we'll talk about this some. However, we'll note that the episode-based measures for 2018 will not be effective. CMS is in the process of field testing 8 episode-based measures for future program years. For 2018, our measures will be based on claims data, so no additional reporting required. And there'll be two things. There'll be total cost per capita. Specialty adjusted measure includes all payments under Parts A and B. And then Medicare spending per beneficiary. The cost of Medicare Part A and B services 3 days before and 30 days after an inpatient admission. But we'll go through these cost episodes groupings a little bit just so you can understand, because again, we expect this to be again in the future, and we can see that CMS is definitely field testing these. CMS has been monitoring costs through different programs such as value-based modifiers, so this is all being completed behind the scenes by CMS trying to basically interpret our claims. And if you've ever looked at a QRUR report, you will see there's information on there such as average cost in an organization for a patient with CHF or COPD, PVD. That is all being tracked through this episode grouping by calculation on the back end through data on claims. So basically today all they have is just exactly what we put on our claims. They're assuming based on an acute episode of an illness or an intervention that's been done, they're tracking costs of that intervention to when the patient's stable. They found that this is not an exact science at this point. And so what MACRA, again, did was bring this to the front end of the cost category. So eventually, under episode-based measures, we will be required to link episodes of care to the diagnosis that is being supported through that care. There's different episodes that they're going to be monitoring. Some are chronic, some are acute illnesses, and CMS will be watching for trigger codes added to claims to allow CMS to start tracking costs and when to stop tracking costs. They're going to require us probably to be delineating through this methodology what diagnoses is associated with what costs. Because, for example, if you had a patient in with pneumonia and a UTI, both are a care episode group. So yet to be determined would be how are we going to delineate on the claim what costs associated with pneumonia and what costs is associated with the UTI. From there, CMS would then track the average cost of these diagnoses in our organization. If a facility or provider would want to kind of gain an idea just today of how you compare, we definitely would encourage you to view your QRUR reports that were, you received under the value-based modifier. It'll just kind of give you a little bit of an idea of how you're going to compare in these different categories and controlling costs. But again, all of that we talk about kind of goes back to the risk adjustment under HCCs. The objective of the episode groups, again, CMS is trying to make us responsible for cost utilization for patients with these diagnoses, as well as provide feedback on the costs associated to care for these patients with the diagnosis, and basically challenge us back, where do we maybe need to tighten our utilization? Where are we falling out of the norm? The third thing was patient condition groups, very similar to HCC scores, but patient condition groups, CMS must consider the patient's clinical history at the time of a medical visit, such as the patient's combination of chronic conditions, current health status, and recent significant history, such as a hospitalization or a major surgery. So if we say a patient had pneumonia, COPD, and history of lung cancer, CMS wants to know those contributing conditions that affect the current patient's health status and where that patient may need additional support. What's the difference between this and HCC scores? HCCs are for the full year. These patient condition groups will be just for an episode of care. So the timeline, this was done before kind of the final things came out. We now know the patient relationship categories are you know, they're going to be required, but it's voluntary at this point. But when it will be required, we're not sure. And then definitely the episode-based measures are gone, but they're not forgotten. And CMS is going to be field testing 8 episode-based measures for future years. So where does risk adjustment fit in? Again, all of these costs are risk adjusted to reflect the complexity of care the patient needs based on the HCC score. How do we operationalize HCC scoring? It's definitely important to bring everyone together to the table for this. You know, this is not a clinician issue, this is not a coder issue, and this is not a leadership issue. This really is an organization process, very similar to, you know, how organizations had to deal with MSDRGs, the same thing. This needs to be a process we follow for every patient, every encounter. It's not a one and done. We don't like, oh, one time and then we're done. This is specific to CMS. However, we know commercial companies are definitely looking at risk adjusting their patients as well. It's just not always as transparent. So certainly understanding HCCs is a good way for all patient populations to understand how we can reflect severity in our data. What are some of the common errors? I mean, certainly not documenting or coding to the highest specificity. You know, if you have in a chart chronic lung disease or you have bronchiectasis, code out very differently, and there will be a difference in the scoring. Chronic or coexisting conditions not documented or left out of clinical documentation. And I think, again, a lot of this is we've been kind of focused on what's the reason for the visit, but the thing that's important is what are all the factors contributing in that visit, and that's the part that we need to get better at documenting. You know, in documentation, I don't know how many charts, history of this, and this. Well, it's not really a history of. A history of it typically means you had it and it's gone. So it's just kind of the nuances of documenting, of how we document in order to allow coders to be able to code these chronic conditions. Some lack of understanding related to diagnosis coding affecting EMM levels. If you code one diagnosis or you code 5 diagnoses, that doesn't impact the EMM level. And then just how many diagnoses that can be included on a claim. You know, a good example is a patient with a long history of mental illness, but they didn't code any in the year of 2016. So if we have major depressive disorder, and so basically, typically what you see documented in a chart is just depression, and that's going to get coded to F32.9. You know, if a patient has depression and they're on long-term treatment, can it be further defined as a single episode or a recurrent episode? You know, if you took away the antidepressant, are they going to recur into depression? Again, a very typical documentation of depression. I've coded it many, many times and never thought twice of it until HCCs. Now, you know, we need a little more specificity in our documentation if we're going to be able to code it more specific and to have an HCC category. Never would I ever promote, you know, documenting to get paid, coding to get paid, and that is not what I'm stating here by any means. But we know, for example, depression does have a major impact in our healthcare system. And so if we don't understand that, you know, when we state depression treated with X, X, and X, and we think that's impacting and it's not, we just need to understand that. Clinicians need to understand that, and coders need to understand that. Another one is obesity. Under HCC category 22, if you have a BMI of 40 or greater, That's an HCC score. Or if documented in morbid obesity, that also has an HCC score. The thing that's interesting about BMI coding is, again, in the DRG system, we can code BMIs off of nursing, dietary, other clinicians' documentation, but we cannot code it if we don't have providers documenting the disease condition of obesity or morbid obesity. So again, we need the clinicians to document the diagnosis of obesity, and then we can code that BMI, but it takes both areas of documentation. This is such a common one. Patients that have had a stroke or a CVA will see in the documentation history of a stroke, and then we'll see right-sided weakness. They never correlate the two together. If this weakness is due to the CVA, it has a totally different code, which is an HCC. So again, it's kind of understanding these things. What are the documentation requirements? We talk a lot about MEET, and this is definitely an acronym used a lot on professional coding. In the hospital facility side, it makes the same, it correlates just as well. A lot of times what we used in the facility inpatient is we would talk about 360-degree documentation. Do we have the risk factors, the clinical indicators, the treatment? Well, MEET is a good acronym to really keep in mind and to share with your clinicians, because I think it's easy to understand and remember. M is to monitor the signs, symptoms, the disease progression. E, to evaluate the test results, the response to treatment. A, assess, address, test, discussion, record, review, counseling. And then finally, treat. What are our medications, our therapies, our modalities? And this doesn't have to be lots and lots of words always. I mean, again, COPD, patient is stable, continue on their home nebulizer treatment, follow-up chest x-ray in 6 months. Right there, I've got the MEET for coding COPD. Again, the hospital environment, we've had a lot more discussion on this. We've talked about this in coding roundtables. We query providers much more in the hospital environment. We have documentation improvement activities. This is where this is all moving over into the outpatient setting, in particular the physician office setting. We need to be thinking about these same things now in that setting, because that might be the only setting that we see these patients in. If they're not in the hospital, we're only going to have our physician claims, and we need to get this done in our outpatient settings. So just some do's and don'ts. Again, this is a lot of times when I talk with providers, the specified diagnosis, aspiration pneumonia, if you know the type of pneumonia, specifying it. Listing the diagnosis with evaluation and treatment. Don't rely on the problem list, and coders cannot code from problem lists. We don't want to clone documentation. We want to individualize it. We want to include those chronic conditions which impact treatment. If a diagnosis is active, we want to list it as active. We don't want to just say history of. And again, we want to now code our claims completely. Before we were kind of about coding our claims to get paid. And again, we can continue on the right, and we're still going to get our fee schedule payment, but it's going to impact us on these other factors. So additional operationalizing opportunities, again, continued education. And I think it's just important. Coding needs to be involved in this. The physicians need to be involved in this. We want to maintain focus. This is an every encounter process. This isn't a one and done. we might only get 1 or 2 chances to see that patient that year, and so we've got to make every encounter be well documented and well coded. And we want to identify if there's trends. Are you not capturing the BMIs? Is that a trend? That would be, those are things that you can kind of look at and maybe work on one at a time to kind of build to get your documentation better. Problem lists are important. They are clues. They are something we should be looking at. But problem lists need to be clean, and that's kind of the problem with the problem list. They kind of get all cluttered up, and then nobody starts to pay attention to them. So that is definitely something that is important. We want to increase our communication between our providers and our patients and our coders. Make sure we're all talking about this. If we have any opportunity to pre-appointment chart scrub, to be able to provide that provider with their chronic conditions so that they can address them with the patient and address them in their dictation. Preventive services, Medicare is definitely paying us to keep patients healthy, and let's take advantage of those preventive services and cover those chronic conditions in those preventive services. If you can embed HCC management tools into your workflow, we're seeing, definitely some of the EMRs, we're now diagnoses that are HCCs are flagged. It's a tool, but again, we need to have a workflow and a process to support that technology. RADV audits, there are going to be audits to this just as audits and anything else, and so it's something we want to be aware of. There are risk adjustment data validation audits. CMS verifies that each diagnosis code submitted is supported by medical record documentation. It can be reviewed annually, and we'll have to submit member medical records to validate diagnoses that were previously reported. And I'm going to put a plug in here, talk to your release of information areas in your HIM departments, because they need to understand this as well. When they want every claim for that patient in a calendar year, they have to submit every piece of documentation from those encounters. These audits are labor intensive on the release of information side, and so we have to recognize that. We have to support that staff, and we have to make sure that they understand that. CMS declared the HCC error rate is approximately 33%. I wonder if a lot of that error is not getting the documentation they need to review. Again, remember, work we do this year will determine our funding for next year. And understand that mapping a diagnosis only has to be done once. But we are able to, they will kind of keep in a tally 5 dates of service to support any one HCC. So let's just say you were audited and one claim got thrown out. Well, if you've got it on 4 other claims, it isn't going to go away. And it's just like any other audit. If it only shows up once in a calendar year, where do you think they're going to audit? They're going to audit on those single times that it's reported, because it's why isn't it reported more than that? So that's just definitely something to keep in mind. So in summary, we just want to educate on HCCs, understand HCCs, implement and monitor so that we're ready for this. Thank you. I appreciate your attention this afternoon.
Okay, great. Thank you, Joy, for sharing this great information with our audience today and taking the time to prepare these very rich slides. Before we jump into our Q&A, I just wanted to remind everyone to type your questions into that questions panel, which is located to the right of your screen, and we'll take as many as time will allow. I did have consistently among the webinars, there's always that question about slides. So if you missed the intro, don't worry. You can access the slides right now. Just go over to the right. You'll see a handouts panel and expand that, and you'll see that little PDF icon, and you can gain access right away to that. All right, so it looks like we have a question here from Marlena, and it reads, if I wanted to be able to calculate a partial HCC score just based on HCC diagnoses, where would I find the HCC score value for the eligible HCC diagnosis?
Okay, there are tables out there from CMS, and I'm guessing we'll be getting a new table shortly, and it does have the diagnoses, and it'll have the HCC score tied to it. And then the thing that you have to really, because I do a lot of manual calculation of HCCs, and it takes time, because you have to then look at the hierarchy, so that you only capture one in that hierarchy, the highest hierarchy, and then the disease interaction. But yeah, there definitely are tables out there, and they have the hierarchy table, and they have the disease interaction table. So that is all out on CMS's website.
Perfect. Thank you for that. And one of the attendees mentioned that the slide on providers, it didn't mention or list mid-levels such as PAs and APRNs. Are they excluded from this?
No, they're not excluded. No, they are part of those providers.
Perfect. And I have another question. Do you have a list of those 5 modifiers for the patient relationship categories, and did you say when these are required to be put on the claims?
Well, okay, so I do have a list. They were X1, X2, X3, X4, and X5. I did find this out on the Medicare Quality Initiatives Patient Assessment website. And what it states is that they're, beginning January 1st, they're voluntary. And it's interesting, because there were other presentations by CMS, and we asked the question about this, and they said they would be required, or claims would be denied January 1st. But since that time, the final rule has come out, and it does state that they're voluntary, but we definitely are recommending that you start using them, especially to get over this learning curve and to understand and hopefully, as other providers are using, these, we can have crosstalk on how do we use these, because I think there's going to be a lot of questions.
Fair enough. Okay. Well, it looks like we are very close to the top of the hour, so I do want to be respectful of everyone's time. So as we wrap up, I would like to take this time to thank our members as well as the healthcare community for joining this call. Region 8 has another webinar scheduled for January 16th, so keep an eye out for a session and registration details for that. Also note, you will automatically be routed to a survey at the end of this webinar, so please share your thoughts and let us know if there are other topics that you'd like to see on this platform, and also be sure to provide the email addresses of everyone in the room to ensure everyone receives proper credit for attending today's event. So thank you again, Joy Krush of Eide Bailly. We are so grateful that you took time out of your schedule to prepare and present today.
Thank you.
And everyone else, have a great afternoon, and we look to see you online in the very near future. Have a good one.